Okay, it's time to start our School of Nursing Research Day oral presentation session. Welcome to our students, faculty, nurses from UCLA Health Hospital, alumni, colleagues. Welcome today. This is the biggest event to represent our research activities at the School of Nursing, UCLA. My name is Donson An. I'm the chair of the research committee of the school. And I'd like to first introduce our Dean Sarna for an opening remark. So please welcome Dean Sarna.
Hello. Hello, everyone. Thank you, Dr. An, for all of the extraordinary work that you and your committee have done, along with our Associate Dean for Research, Holly Devon, to make this happen. One of the good news, the good things about being virtual is we could not fit you all in our auditorium. So we have a space where we can celebrate nursing research at the top public research university in the land in a beautiful day in Los Angeles, where we, for the past several days, have not had any deaths from COVID-19. So lots to be grateful for. I especially want to recognize the students, especially the new PhD and DNP students who may be sharing their research and scholarly projects for the very first time. Please be sure to look at the poster sessions. I also want to acknowledge our terrific faculty who are taking the time to share their research with you today. You know what they say about research? If you don't publish it, it didn't happen. And in a sense, if you don't share it, who cares? So this is an opportunity to share and also to discuss the opportunities for implementation. We are so thrilled to be part of a large academic health center with Karen Grimley, our chief nurse executive. This is the very last time that I'll be able to welcome you all to such an illustrious event. And I'm hopeful that the next dean, Dr. Lynn Zahn, is actually part of our community of scholars today. Welcome, Lynn. We're looking forward to having you celebrate all of the wonderful nursing research at UCLA. So Dr. An, thank you. Again, thank you to the committee. Thank you to Benisa Salem for creating some magic around all of the virtual posters. I am very, very grateful and very, very proud. Thank you.
Thank you, Dean Sarna. So I'd like to start our presentation. Before that, I have several notes. We selected 4 stellar our faculty today, and each presentation is going to be 15 minutes, followed by 10 minutes question and answer section. All of our audiences are muted. So if you have questions, please use Q&A features, which is you can find the bottom right-hand corner to type your questions. At the end, Dr. Benisa Salem will read your questions, and the presenter will answer your question. So plus all of the presentation and QA session will be recorded, and it will be remained in the website for this research day. So you can revisit anytime. So those are the small notes that I like to remind you. So let's start. I think we are ready. First speaker is Professor Nancy Pike. She's going to talk about her research titled Understanding the Heart and Mind in single ventricle heart disease and research update. Please welcome Dr. Nancy Pike.
Thank you so much, everybody. Good afternoon. Thank you, Dr. Ahn, for inviting me to speak today. I just would like to make sure everybody can see my screen. Is that correct? Okay.
Looks good. Yep.
Thank you. I'm very excited to be here today. And actually, to be honest, I've never been on a Zoom meeting with over 200 participants. So this is wonderful. I'm a biobehavioral neuroimaging researcher, and I focus on children with congenital heart disease, in particular, single ventricle heart disease. My clinical practice of over 28 years as a nurse practitioner in this population has definitely informed my research, my questions, which have typically been expressed, or concerns from patients and families, in particular related to cognitive outcomes, memory, and school challenges. So my focus has really been on ways in which I can improve outcomes in this patient population. So some of my research discussions in this presentation is currently supported by the following NIH-funded or School of Nursing-funded projects. I will be highlighting some of the recent findings that have been published, as well as some interesting preliminary results that we're working on future grants for. Just a little overview for those of you in the audience. Congenital heart disease is the most common congenital birth defect in the United States. Single ventricle heart disease is a subgroup of complex congenital heart disease and often requires 3 to 4 palliative heart surgeries before the age of 4, culminating in the Fontan procedure. This operation helps to alleviate cyanosis, and it decreases the workload of the single ventricle by redirecting venous blood flow. Here you can see my pointer to the lungs through an external conduit that is outside of the heart, and it is not powered by a ventricle. However, this creates a very unique physiology, and over the past 4 decades that we've been following the outcomes of patients after the Fontan procedure, there is a long-term multi-organ compromise that we see, not only in the brain highlighted below here, but also in the liver, the kidneys, the intestines, and the bone and the muscle. My earlier work identified 50% of this group have cognitive deficits, or we can look at it positively in that 50% are doing well. But there is a distinct pattern of mild cognitive, mood, and behavioral deficits that I will be showing you in my next slide. Many will have these deficits into adulthood, which can impact educational achievement, employability, ability for self-care, and quality of life. We see this neurocognitive signature or pattern of deficits across the lifespan. In infants here, we can see motor and speech delays as well as feeding issues. And as we progress along into school age and adolescence, we see more deficits in attention, executive function, academic skills, visual and spatial issues, as well as social and emotional related to relationships, anxiety, and mood related disorders. Oftentimes, these things may not become apparent until high school, when a higher level of organization skills are required to problem solve, plan, make decisions, a lot of those things that are crucial with executive function. But the real question that we have here is, what will this signature look like later on in adulthood? Will these deficits stay static, or will they worsen with age? This figure, published by Morelli in 2016 in Circulation, actually summarizes some of the factors affecting the brain across the lifespan in congenital heart disease. At the bottom here, we see that there's the heart, and then we have exposure to injury at the various age ranges throughout into adulthood. And then up top here in the gray area, we see expression of the injury. And this is what we see related to the brain changes. Early on in the prenatal period, injury and dysmaturation, in which brain volumes are smaller than healthy controls. In childhood, we see more white matter injury during their stage surgical procedures and developmental anomalies. And then in aging, we see reduced cerebral blood flow and brain volumes. Interestingly, my work will highlight that we are seeing these changes now in adolescence. We know that there is a host of biologic, genetic, and environmental factors that can contribute to these deficits, and these adverse neurocognitive outcomes are most likely multifactorial, they're interrelated, they're cumulative and likely synergistic over time. And when we see towards adulthood and in geriatrics with acquired conditions that can develop with aging, as in this box that I'm pointing to, we are adding insult to already areas that we're finding injury in. So that question of what we will need later on in adulthood are things that we're slowly teasing away at. I was very fortunate over the past 2 years to be involved in 2 very important scientific statements looking at the single ventricle population through the American Heart Association, addressing these key issues of neurodevelopmental outcomes, mental health, and medical comorbidities of end organ damage associated with prolonged exposure to the Fontan circulation. And the second article looking at reduced infant mortality using a home monitoring program to help identify early signs of cardiovascular decompensation. And for the APRN students or APRN colleagues in the audience, this study was one of the most successful APRN interventions in reducing mortality and morbidity in these infants during between the first and second surgical procedure, where the highest risk of mortality and morbidity are. I'm highlighting down here a colleague of mine, Mark Rodefeld, underneath my name here on this publication. I will be addressing him and a project that we are working on later on. So we know that we have many important structures of the brain that individually and together are vital to cognition and function. I will be highlighting 2 recently published papers looking at the hippocampus and mammillary bodies, which are highlighted on the figure here. These areas of the brain regulate memory, emotion, motivation, as well as learning. And I also highlighted the frontal cortices. And we just finished analysis in this area, and we will be presenting our findings at Pediatric Grand Rounds at Ronald Reagan Medical Center this Friday. This first paper was published in Brain and Behavior in 2021, where we manually traced 64 subjects and we calculated their mean volumes of their hippocampus. And you can actually see in this 3D image over here on your right, the right hippocampus and the left hippocampus. These volumes were smaller in the single ventricle group compared to the controls. And we controlled for covariates such as age, gender, and total brain volume, which can vary based on the individual. And when we controlled for those things, only the right hippocampus remains significant. And in the 3D imaging, you can see on your screen here, in the red are the areas that had significant injury. And this is showing us actually a lateralization in our findings here. And we were thinking on what the possible cause or explanation could be, though we don't know for sure. All of the single ventricle participants in this cohort had, as part of their first stage palliative procedure, a right modified Blaylock-Townsend shunt. And in the picture here below, you will see that this is a synthetic tube graft that is connected typically from the innominate, subclavian, or the right carotid artery, and it is connected to the pulmonary artery. And this is often the only source of pulmonary blood flow for many of these children. And as the blood travels out this single ventricle, it will go across in some an augmented aorta and down to the descending aorta. Some will perfuse to the brain. And then there is a possibility of creating what we call a steal effect, as some of this blood flow in systole will travel to the lungs, potentially reducing the amount of blood flow to the right hemisphere and potentially the right hippocampus. Currently, we use what's called a sono shunt, where that synthetic tube graft is placed in a different location, where it goes from the ventricle to the left pulmonary artery. And this actually mitigates any sort of potential stealing effect that could be from the cerebral artery. So this is one potential cause that we thought why we're seeing the findings that we're seeing. And all of these volumes correlated with many of the cognitive and mood scores that these individuals were tested on. And also there's the potential for reduced cerebral blood flow related to structural issues within the aorta, and many have augmented or narrowed areas, residual narrowings in that area, which could possibly play a factor. This next paper was published in 2020 in Pediatric Research, where I mentored Cristina Cabrera Minos, who is a Meccan student graduating this year. And she is also my GRA for some of my research that I've been doing. And we looked at the mammillary bodies, which is another key structure in regard to memory and processing memories. And you will notice here that both the left and the right mammillary bodies the volumes were statistically significant. They were smaller than the controls. And if we look over here on the picture on your right-hand side, if you look at the very bottom under the control, you'll see that these are the mammillary bodies. They're very small, round, circular, pea-sized shaped structures. And if we look over here at the child that has single ventricle heart disease, we notice that many of them are absent, or there are small remnants of the mammillary bodies. So this was also a significant finding for us, and many of the cognitive measures of memory and mood related testing that we did correlated with these volumes that we're seeing. So I mentioned already a little bit about cerebral blood flow. So what about cerebral blood flow, as well as looking at the ventricle type? This goes into my second R01, that we looked at cerebral blood flow in this population related to a single related to a single ventricle compared to teens with two ventricles. And we noticed that overall there was global reduced cerebral blood flow in areas that support cognitive and mood related functions. We dug a little deeper, and I thought about this a little bit more, and I thought, in the single ventricle population, where you're born with either a single left or a single right ventricle, the right ventricle is not designed to be the systemic pump to last your lifetime with. So I hypothesized that maybe the kids with the single right ventricle had more reduced cerebral blood flow. And here's an excellent picture of our preliminary findings that we're using for a new R01. You can see in the glass brain image on your left-hand side, the darker areas show significant reduced cerebral blood flow. And you can see this widespread reduction highlighted in the red and yellow areas in the brain up top. So this, we thought we need to take a look at a little bit closer, and why would this group have more than the single left? And the first thing that comes to mind is function, ventricular function, or in some of these children's cases, it could be structurally related. So the innovative thing that we're adding to this new grant that we are submitting is using, in addition to a brain MRI, a cardiac MRI. So we can actually evaluate ventricular function. And you're probably saying, well, why not use an ultrasound? In a single right ventricle patient, the gold standard is cardiac MRI to assess ventricular function versus ultrasound. So while we're there, we're going to be looking at a chest MRI and assessing function, as well as potential structural obstructions to cerebral blood flow. But the really big, and I think most important question here that we have to figure out in order to help these teens in regards to their school challenges that they are having and parent concerns is this brain injury amenable to cognitive retraining? And my current pilot study that I have here that's funded, we're interested in really looking at neuroplasticity. And if a targeted cognitive retraining program here, looking at working memory, can help restore or promote neurogenesis to these areas that are injured. This project got delayed because of COVID, as well as a new Cogmed version came out in January of 2021, and we really couldn't have participants switching over into programs midway during the intervention. So we waited, and now we are waiting to start in June. We have teens ready to go, and most parents had requested that we wait until school was out, because as you can see under the intervention section here, it's pretty lofty, and there is a time commitment associated with it. It is a 5-week intervention for 50 minutes, and they do 5 times a week. And you can see by the picture over on the side, this is very kid-friendly. It's very interactive. There's scoring mechanisms in which it will regulate itself up or reduce its level of intensity depending on how the child answers and responds and goes through the various tasks for each session. And most of them, there's a fun interactive piece where they can earn points and develop a city and buy certain structures to actually develop this little village that they give them to work with. But we're looking at the outcome measures of brain MRI and working memory testing before and after this 5-week intervention. So we're really excited about getting this going in June. And for time's sake, I was going to show you a little example of how this works, but it just gives them their various activities to cover. And this is the little village that I was talking about on how they can develop that. So what about the impact of self-care here? This is an important outcome measure that we need to have available to us to measure to see if this intervention actually improves their ability for self-care in the future. Unfortunately, we do not have any disease-specific tools for self-care in the CHD population. There's no objective measures for good self-care, not like the adult heart failure population where you could measure their BNP, or in the diabetic population, you could measure their hemoglobin A1C. So I developed the Congenital Heart Disease Self-Care Questionnaire, and it's undergone extensive content, criterion-related validity, rubrics for grading. We identified low to moderate self-care in this population. There were significant strong correlations with cognitive and psychosocial measures, and our clinical variable was increased emergency room visits. And the 4 domains that are part of this questionnaire, knowledge and adherence, were the 2 that were statistically significant with increased emergency room visits. So these really are the key, which makes sense in ability for self-care and measuring it correctly. And lastly, I want to let you know that we're all of us that work in the congenital heart disease population, we are ready for a moonshot. And what that means is it's just a phrase that was coined for something that's groundbreaking, that's monumental, that's happening out there that could have really a significant impact on the population. And Dr. Rodefeld here from the Indiana University is a colleague of mine that I've known for probably over 20 years. He actually created an implantable impeller pump that gets inserted over here, you can see by my arrow, into the Fontan circuit to propel blood to the pulmonary vasculature. And there is a desired pressure that's set, which is similar or would be acting like the right ventricle. Though we cannot grow or develop a new ventricle yet, and I say that yet, this pump has the potential to create 2 ventricle physiology in patients that only have 1 ventricle. The other good news, it could potentially mitigate end organ mortality and morbidity, as well as decrease the number of open heart surgeries that these children will need in the future. As I keep telling Dr. Rodefeld, he hit the NIH jackpot by his $9 million 5-year grant that he received. And I will be involved with him in year 5 of that grant as we develop the human clinical trial associated with this. We are currently undergoing blood compatibility and animal studies with this device. So the human clinical trial we're looking at in about 3 years. So in conclusion, cognition, particularly memory deficits, are common in adolescents and young adults with single ventricle heart disease. Our findings show significant brain tissue injury, volume loss in various important structures that correlate with memory and mood deficits. There is reduced cerebral blood flow to these areas that support cognitive function. And now we're currently exploring the potential causes why, such as single ventricle function or heart structural related issues. And the really big question that's important to our patients and families is if this injury is amenable to change using working memory retraining, and can this improve self-care? And I think all of us in this community are ready for this moonshot to come. We get questions all the time by families that know about this mechanical assist device that can be implanted and potentially create improved outcomes in this population. And I want to thank the interdisciplinary research team that I work with. It definitely takes a village, highlighting Dr. Rajesh Kumar and Dr. Baswati Roy, who actually helped me get all these beautiful brain MRI pictures that I've shown, and also to our community partners, Children's Hospital Los Angeles, Mattel Children's Hospital, and Camp del Corazon, and thanking them for letting me shamelessly post my research to help recruit participants all over California. And thank you very much. And I can entertain questions at this point.
Thank you, Dr. Pike. It is very fascinating research. So audiences, you are muted. If you have questions, please use Q&A function box, which you can find right bottom hand of the corner. Type your questions so Benny-sir can read your question. In the meantime, I have a question to Dr. Pike. So it's quite fascinating. In particular, the memory function is lost. This is due to the susceptibility to hypoxia?
Yes. So it's multifactorial, which there are many different factors that could contribute to this injury. A lot of the research that we've done through the Pediatric Heart Network, which is a huge NHLBI funded network that I've been involved with for many, many years. We've actually done randomized surgical clinical trials. And interestingly, which you think the surgical variables of having hypoxic ischemic insult from being cyanotic for the first 3 years of life and undergoing 3 open heart surgeries and potentially more, depending on their anatomy and physiology. You would think that maybe these surgical variables are actually the main contribution to what we're seeing. And actually it's not. We're showing that there are a lot of innate factors that are coming into play. looking at their social economic status, the environment that they're in. And more so, the contributing factors are the post-operative care. For those nurses that are in the audience that work in the ICUs that manage these patients after surgery, what we do in the post-operative period and the waxes and wanes that we see with hemodynamic fluctuations and instability in those periods can cause that reduction in cerebral blood flow or hypoxic ischemic sorts of injuries that can contribute to what we're seeing. But there's also genetic factors that can play into this as well too, as some of these children have genetic syndromes which can have some cognitive developmental delays associated with that.
Well, that's very fascinating. There seems to be a lot of work to sort out those multifactorial factors. There is a question, so Benissa, maybe you can chime in to introduce a question.
Sure, of course. Dr. Pike, thank you for your thought-provoking presentation. Teresa Gonzalez asks, in your CHDSCQ, you mentioned knowledge is one of the most important domains. Can you elaborate as to how you are measuring knowledge and be more specific?
Absolutely. So for knowledge in this population, in this questionnaire that we developed, it's important for these children to be able to articulate their clinical condition if by chance they have to present to the emergency room. And many of these kids rely on their parents to explain what's wrong with their heart, what surgeries they've had done in the past, and what medications they take. So we actually, part of the questionnaire is actually answers that they have to write out. And we evaluate whether their answer was correct, partially correct, or incorrect. So they get scores based on their response. And how we assess knowledge was we asked them to please write out the name of their heart defect. And also another question that we asked them to write out, could you identify 2 symptoms that would require you to call your doctor or go to the emergency room? We also asked them to write out what medications do you take and what is the dose and how often do you take them? And then we asked them another question on what that medication does, as well as why they need antibiotics before having a dental procedure to address their issues of having infectious endocarditis and the prophylaxis for that. So we asked them those various questions, and it was quite astonishing how many children did not know those answers and could not answer those questions. So specifically, we honed in on those important things that they need to know to be able to convey to healthcare providers, because this group was aged 14 to 18 and they are transitioning to adulthood. And it's important that they're able to speak for themselves and take care of themselves as they transition into adulthood.
Thank you, Dr. Pike. I believe we have some time for 2 more questions. Sandra Dewar asks, have you observed any risk for seizures or the development of epilepsy in this population?
That's a really good question, and that has been out there, in which the incidence of post-operative seizures in this group, and I don't have the exact percentage of them, but in the cohort of single ventricle kids that I have, nobody had a particular seizure disorder or a diagnosis of epilepsy. Many of the seizures that we see in this population can be during the postoperative period, and that can be related to low blood pressure. It can be related to electrolyte abnormalities and other things that we see in the postoperative period. But that diagnosis attached to them later on in the cohort that I have, and then in another just general congenital heart disease population of 200 that I have in that group, there is maybe only 1 or 2% that actually have any permanent diagnosis of a seizure disorder. But that's a great question.
Thank you, Dr. Pike. And another participant asks, is the Sanso versus Blaylock, is one better over the other for brain perfusion?
Okay, so that's another good question. We don't know which one is better versus the other for brain perfusion. That has not been looked at. We do know through the first surgical clinical trial that I was involved in for 5 years of my life was when we randomized infants born with single ventricle heart disease, in particular hypoplastic left heart syndrome. They were randomized into getting a BT shunt versus a Sano shunt. And that was a wonderful publication that got printed in the New England Journal of Medicine that I was on. And that clinical trial showed that the Sano shunt was better for the targeted, for one of the targeted endpoints was reduced mortality in the immediate postoperative period. That shunt was better. But in the long term, that shunt started to phase out because you'll notice it's connected into the ventricle. So over time, where that shunt was connected, they can have reduced ventricular function in that one single ventricle, in that single right ventricle. They can have reduced function from that over time. So that clinical trial did show the Sano to be a little bit favorable in the immediate postoperative period, but there's no information that shows that one shunt perfuses the brain any better than the other. But I would hypothesize that the Sano shunt probably does that better.
Thank you so much, Dr. Pike. You do have a few additional questions, but due to time, I think we need to turn to our next speaker. Thank you very much.
Thank you, everybody.
Thank you, Dr. Pike, and thank you, Benissa, for introducing questions. And Q&A session remains, so please use that function to leave your questions. Nancy will answer those questions. Next speaker is Dr. Sarah Choi. She's an associate professor in our school. She is going to talk about her research today entitled Brain Injury, Cognition, and Glycemic Control in Adult with Type 2 Diabetes. So please welcome Dr. Choi. Sarah, you are muted.
Thank you. Just let me get this, put it on slideshow. Okay, can everybody see my screen?
Yes, looks fine.
Okay, great. Let me put this. Okay, good afternoon, everyone. Thank you, Dr. Ahn, for inviting me to the School of Nursing Research Day. I am a behavioral a researcher with a clinical background as a family nurse practitioner, and my program of research focuses on chronic disease self-care management, primarily on type 2 diabetes. Today, I would like to talk about my research on brain health and diabetes self-care, and also share with you some of the findings from this study. So type 2 diabetes is an important national health issue and also a serious global health problem as well. More than 34 million Americans have diabetes. That is about 1 in 10 people have diabetes, and approximately 90 to 95% of them have type 2 diabetes. Self-care is critical to improve type 2 diabetes diabetes outcome, and yet many people find it difficult to achieve good self-care. Self-care tasks are complex and require multi-domain cognitive skills and processes, including memory, attention, planning, calculation. Therefore, intact cognition is required for adequate self-care. We know cognitive abilities are linked with brain structural status, yet we do not know whether the brain changes are related to self-care abilities and the impact of glycemic control on brain structure and self-care. So my current NIH-funded research, in collaboration with a brain imaging expert, Dr. Rajesh Kumar, examines relationships between brain tissue integrity and self-care abilities in adults with type 2 diabetes. This study has 3 aims and compares brain structures between type 2 diabetes and non-diabetic healthy subjects via MRI, and evaluate the relationship between brain structural changes and self-care management in type 2 diabetes subjects. It also aims to determine the impact of A1C levels on brain changes in type 2 diabetes subjects. So we are currently in project year 3 and are recruiting subjects, collecting data. We are also analyzing data, and we have published some of our findings. So today I'm going to present findings on brain injury, cognition, and glycemic control. As mentioned earlier, intact cognition is critical for good self-care. However, cognitive impairments are common in patients with type 2 diabetes and adversely impact self-care management and glycemic control. Unfortunately, brain injury in sites that control key cognitive, we call it executive functions. This area is prefrontal cortices specifically, and its relationship to cognition and glycemic outcomes in type 2 diabetes patients remain unknown. So just to refresh your memory, the prefrontal cortex is the cerebral cortex covering the front part of the frontal lobe. Indicated as the purple area. And this brain region has been implicated in complex cognitive behavior referred to as executive function, such as decision-making, working memory, attention control, inhibitory control, cognitive flexibility, reasoning, problem solving, and planning. The basic activity of this brain region is orchestration of thoughts and actions in accordance with internal goals, which is highly relevant to diabetes self-care. Our aims for this particular project analysis were to evaluate the prefrontal cortices density in type 2 diabetes, compared with age and sex-matched non-diabetic healthy controls, and also examine the relationships between prefrontal cortex density and cognition and glycemic control in type 2 diabetes. Our sample included 28 type 2 diabetes patients and 47 healthy controls, and we used the brain MRI, MoCA, the Montreal Cognitive Assessment tool, to measure cognition, and also finger stick point of care HbA1 hemoglobin A1c test. And our MRI data processing and statistical analysis included gray matter density maps, the region of interest analysis, and partial correlation analysis with age and gender, age and sex as covariates. So the results showed significant differences in BMI, MoCA scores, and PFC, the prefrontal cortex gray matter density between type 2 patients and control subjects, as you can see here, and revealing worse cognitive impairment in type 2 diabetes. Scores are lower, and then also this here suggesting brain injury in sites that control cognition. That is basically a prefrontal cortex area. And the findings are shown on these brain MRI images. And the color bar here on the right lower corner here indicates T statistic values. So the greater the magnitude of T, the greater evidence, the stronger evidence that there is a significant difference. So, and also the color blobs indicate regions with a significantly reduced gray matter density in type 2 diabetes compared to controls. So you can see reduced gray matter density in prefrontal cortices in type 2 diabetes subjects compared to controls in both left, here indicated as A on this axial and corner view, and also on the right side, here, prefrontal cortices here on this axial and sagittal view. There were other brain areas that showed reduced gray matter density, but our focus was on the brain regions that control cognition. Here are marked the regions of prefrontal cortices sites. So this table shows our correlations results, and we found positive correlations between prefrontal cortices gray matter density and cognition in type 2 diabetes controlled for age and sex, meaning reduced gray matter density was correlated with lower cognition scores. We also found negative correlations between prefrontal cortices gray matter density and HbA1c values in type 2 diabetes controlled for age and sex, as you can see here, which means reduced gray matter density was correlated with higher A1c values, which indicates poor glycemic control. The significance level here is P less than 0.05. So on these brain MRI images, you can see brain sites of negative correlation between prefrontal cortices gray matter density and HbA1c values in type 2 diabetes. Actually, this is, this is a correlation showing between MoCA score, the cognition score, and the prefrontal cortices gray matter density in type 2 diabetes. Both left and also the right side of the prefrontal cortices. And here, these images show negative correlations between prefrontal cortices density and HbA1c values in type 2 diabetes. And this is the specific site in prefrontal cortices that had negative correlations between the density and then the HbA1c. So in conclusion, our findings show that patients with type 2 diabetes have a prefrontal cortex brain damage indicated by reduced gray matter density compared with age and sex matched healthy controls. And prefrontal cortices brain damage is associated with cognitive deficits and poor glycemic control in type 2 diabetes. So further investigation is needed to identify causal relationships between HbA1c and brain changes in type 2 diabetes. We also need studies to examine possible interventions to enhance brain neurogenesis and its impact on HbA1c via improved in cognition. So our study findings have some clinical implications. Protecting prefrontal cortices from injury and repairing existing damage to the brain region may have a significant potential impact on preserving cognitive functions and improving glycemic control in type 2 diabetes patients. However, it may take time to fully understand the causes and mechanisms of brain injury in type 2 diabetes and develop new therapies to treat brain injury. So in the meantime, we may need to consider alternate ways to preserve brain tissue integrity in type 2 diabetes, as well, and also, continuing with current evidence-based recommendations, including exercise, nutrition, excellent control of blood glucose, and cardiovascular risk factors in our type 2 diabetes patients. So I would like to acknowledge the funding support by the NIH and NINR, and also acknowledge our interdisciplinary team. Dr. Rajesh Kumar is my principal investigator, and we have Dr. Mary Wu and Dr. Brecht from School of Nursing, and also Dr. Fabian Mueller, our clinician co-investigators from UCLA Health Endocrinology, and our neuroscientist, Dr. Baswati Roy, who really helped to create all these great brain images. So with that, thank you for listening. I'm happy to answer any questions you may have.
Thank you so much, Dr. Roy.
Go ahead, Benissa.
You have one question at this time. Dr. Devon says that you have very intriguing research, and thank you for this excellent presentation. Have you stratified patients according to duration of diabetes diagnosis in comparing brain structure?
Thank you, Dr. Devon. That is an excellent question. I should also have mentioned it during my presentation. So our sample size is very small. The type 2 diabetes samples size is very small. So that really limited our ability to include other very important covariates. And you exactly pointed one very important variable, that is the duration of diabetes. So So previous studies by other researchers have shown that the duration of diabetes matters in terms of the brain injury, the degree of the brain damage, and usually the less than 1 year of diagnosis. There isn't much difference between newly diagnosed diabetes versus diabetic patients with a longer duration. The healthy control. So that 1 year duration, like initial period of the diagnosis, may be such a great window of opportunity for us to preserve and protect the brain tissue from other insults related to the diabetes conditions such as like hyperglycemia and other vascular factors. So to answer your question, yes, we definitely plan to look at our outcome or the relationship among all these major variables in consideration of duration of diabetes. But this particular analysis, we were not able to include that because of not sufficient of the power and small sample size.
Thank you, Dr. Choi. To follow up on that question, have you considered measuring the potential impact of inflammation? Asked Dr. Devon.
Potential impact of inflammation. Yes, that is a really good point, because the inflammation is one of the main factor driving all these vascular changes, the cerebral vascular changes, also the blood barrier functions and all that. So we definitely want to look at that component in our future studies. But the current study does not really include that either the biomarker for the inflammation.
Thank you, Dr. Choi. And Jolene Smeltzer asks, were there any brain tissue differences among well-controlled versus poorly controlled type 2 diabetic mellitus status?
Yeah, thank you, Jolene. That is another excellent question. So actually, that is what I'm currently working on with actually manuscript. That results was presented and from different analysis. The result. So yes, there is a difference in gray matter the volume in terms of a well-controlled and poorly controlled diabetes patients. So so that indicates the importance of good glycemic control and good blood glucose management, because the longer term, the longer exposure of hyperglycemia and poorly controlled diabetic patients can definitely have worse impact on their brain tissue integrity and also associated cognitive functions.
Thank you, Dr. Choi. Your last question is, along the lines of duration time of diabetes, was the higher the hemoglobin A1C, did that correlate to worsening cognitive function?
Higher along the line of the duration of diabetes, we did see the worsening cognitive function with a high HbA1c, but unfortunately that analysis, because of we are still recruiting small sample size, we won't really include the duration of the diabetes as the covariate. But I am my gut feeling is that we are going to be seeing a significant difference between in terms of a brain tissue damage between diabetic patients who have a higher HbA1c versus low HbA1c, and also impacted by the duration of their diabetes as well.
Thank you very much, Dr. Choi.
Thank you, Dr.
welcome.
Choi.
Thank you.
It was an amazing presentation.
Thank you so much.
So the next speaker is Dr. Dorothy Wiley, a professor from our school. She's going to talk about her research entitled Sex Hormones and Anal Precancers. Please welcome Dr. Wiley.
Am I muted still?
Nope, sounds good.
Okay. All right. So I'm going to talk a little bit about sex hormone research that has evolved in the study groups that I work with over the last many years. So I'll take you really quickly through sort of what our experience level is. I started working in HPV research in 1996. I've been working in HIV research since 1992. So whether it's about the vaccine, which we were involved in the original studies and the nonavalent vaccine, or related to the work we're going to talk about today, related to anal cancer and anal cancer precursor lesions, over years we've participated in a lot of different research enterprises that are collaborations with large study groups. So the dark blue that's highlighted here are the studies that over time have informed much of this research from our original studies, and also our R01. And it also gives you a feel for the kind of research my study group has been involved with since 1999. So to give you a little bit of background about why we care about this, the incidence of anal cancer in HIV-infected adults has been rising, and has been rising since 1996, since the inception of highly effective antiretroviral therapy. People just didn't survive long enough to get their cancers prior to that point. And so we saw a huge uptick in the number of cancers between 96 and 2004-ish. And they've stayed largely the same, possibly ticked down a bit. But this is a histogram to just give you an idea. This is work that Ingles Group has done. And what they've done through the National Cancer Institute is looked across the many studies and that are across the United States that relate to HIV infection. And what they find is that gay, bisexual, transgender, and other men who have sex with men form the highest risk group. And so if you look at their case rates, there are over 80 cases per 100,000 in a disease that in cis men in the general population is at a rate of about 1.4 cases per 100,000. So if you look at these little red bars, they're telling you that standardized incidence ratio. And so what you're seeing, if you read down the right column, is that the relative to the general population, these rates are over 35-fold higher than you would expect to see them in these populations of males. In the other groups of males who are infected with HIV, the rates are a little bit lower, but they still are abnormally high. And in female cis women, you tend to see rates also that are over 10-fold higher than you see in the general population. What's underappreciated in HPV disease in the general population is that anal cancer is actually higher, has a higher incidence in women than it does in men in the general population. You tend to see that their rates are about 2.4 cases per 100,000 versus 1.4 cases per 100,000 in men. Okay, so this is to tell you a little bit about the natural history of disease, to keep this in mind as we go through this idea of why we came to to talk about sex hormones and think about them. And so this is taking you from normal epithelium, where infection begins, through microabrasions and trauma, where the virus actually travels down and infects these basal cells. And then what you'll see is that in normal epithelium, this is very organized, stratified epithelium. Everything looks very compartmentalized. When you start seeing low-grade SIL, which is squamous intraepithelial lesions, these relate to these early lesions that are often, in fact, most commonly reversed, but you'll start seeing dysplasia that affects through the layers of the stratified epithelium. High-grade SIL is considered a cancer precursor, whether you're in the oropharynx, in the anal canal, or in the cervix, and they all have the same characteristics. You tend to see a lot of disorganization, hyperproliferation. You see a pushing on borders, which is what they're showing you with this sort of perturbation of this basement membrane. And then with cancer, for those cases that advance to cancer, you see this throughout the entire epithelium. It takes over the stratified epithelium, and you see breakthrough into the underlying stroma. At almost any of these stages, we can see spontaneous regression, probably the most commonly in these low-grade infections that occur early in disease. When you get into high-grade SIL, I have some men that have been under observation since 2002 with my studies, and they've still remained at high-grade SIL. Some of them have reversed with treatment from various folks in the community, providers in the community. The SPANK study out of Australia is suggesting that maybe 11 to 18% of these high-grade SILs will revert to normal, potentially. So that's hopeful. This gives you a look at what the histology is that we're looking at when we look at these lesions under the microscope. A and C are telling you in low-grade dysplasia the kinds of effects that we see in Pap testing. And this is a high-grade dysplasia under the microscope. And so what you can see is that the cells are so very much more abnormal in this slide, this Pap slide. And so you see hyperchromatic nuclei. They're very dark and dense. You don't see this sort of, they always describe this as being sort of a tissue paper appearance, as if somebody wadded a tissue paper and wet it a little bit and dropped it on a slide. That's not at all what you see with high-grade dysplasia. And again, when you look between the two cuts on the blocks for their biopsy, you tend to see real differences. You see a lot more pushing of borders. You see a lot more darker hyperchromatic nuclei, and they tend to penetrate throughout the stratified epithelium. And you'll even see in these top layers, you'll see dividing cells still. You generally speaking will not see cell division, mitosis, above in the top third of the stratified epithelium. So you know you have some problems. So the reason we were interested in this is that I came up in a literature that really is an indictment on estradiol, which I always find fascinating. So this is an example. This is Jennifer Smith's very good analysis. And what she was looking at in these groups of HPV infected women that they knew by documentation were HPV infected. And she asked the question of, what is the effect of oral contraceptive use? Because that's the dominating conversation in women's health that relates to estradiol. You know, in the premenopausal group. And so the long and the short is that when you look at this, she had 2,600 women in this first set of studies that they evaluated. And what they found was with less than 5 years of exposure to oral contraceptives, you didn't see any increased risk for cancer. However, when you move down to these other two groups of 5 to more than 10 years of exposure, you tend to see what looks like a dose response. And in fact, there's close to 5,000 women in this group over time. And what you tend to see is that with the 5 to 9 years, you're seeing a barely statistically significant increase of about 30% risk associated with 5 to 9 years of oral contraceptives. And if you move to more than 10 years, the risk goes up to about 2.5-fold. So coming into this literature, I was very interested in testosterone in men because that's become the new hormone that is affecting men over the last 15 years has been just an explosion of prescriptions for testosterone. So I just wanted you to see, if we think about this as a consort diagram, there's actually a logic, and I'll take you through each one of these steps for these 3 studies that actually support all of this work. So this is showing you the first study that we did. This is actually our second study. We did a convenience sample in the max, and then we came back and we actually did this study full out, where we were using cytology specimens. There were about 1,500 men that were enrolled in this study. And for those men, we were able to isolate cryopreserved specimens in the banks that we had that we knew were within 24 months. Prior to their HPV testing. And what we did was we went in, and with that cryopreserved specimen, we tested to estimate the albumin, the sex hormone binding globulin. We also estimated total testosterone and estradiol using LCMS. And then from that, we estimated the free testosterone in serum. And we also tested for 37 different HPVs, not just HPV 16 and 18. But the reason we concentrated on HPV 16 and 18 for these anal infections is because they drive most of the cancers. Somewhere between 80 and 85% of anal cancers are caused by HPV 16, and another 5% are caused by HPV 18. So you're really looking at 85 to 90% of these anal cancers are being driven by these 2 viruses. Okay, so this is just showing you and reminding me to tell you that this was a multivariable adjusted study. And so most of all, what I want to show you is that what we found, which was really consoling, given that it was very close in the estimate that we had from our convenience sample earlier, is that with every increase, every natural log increase of the free testosterone in serum, we found about a 1.9-fold increase of their risk of being HPV 16-18 infected. What we didn't expect to see, and we had this opportunity to measure estradiol, we went in hypothesizing from the women's data that higher levels of estradiol in serum would actually increase risk. And what we found was that, in fact, it decreased risk, and it decreased it approximately 1.47-fold for their infections. And so we were puzzled by this, and we've continued to be puzzled, largely because people have, a lot of the male scientists that I work with, especially related to our testosterone work, but now with our estradiol work, they're really quite curious about what I suggest we do. In fact, I had one of my colleagues say to me, well, Dottie, what do you want to do? Give every male out there estradiol to give them female sort of phenotype. And that was not at all what I was thinking. I was rather surprised. So the other thing to let you know that our analysis is on track is that, as would be expected, people that were positive for others of these group 1 oncogenic viruses, there are a total of 12 of them. We measured 2 of them as our outcome variable, but those who had the other 10, any of the other 10, were about 1.65-fold more likely to have HPV 16-18 infection. And that's very consistent with the literature, because what we tend to find is that sex is not a random event, and therefore these sexual networks, there tends to be higher and low risk sexual networks. Okay, so the take-home message from this first study was actually that this higher serum-free testosterone increased the risk for HPV 16 and 18. And why that's relevant in HIV-infected men is that it is often the case that while you do not see a change in the decline of their testosterone with aging, what you see is that the slope is the same, but the onset is about 10 years earlier. And that was one of the things my colleague who's part of this work, Todd Brown, had found in an investigation that sparked my interest and actually led to that first study when we looked at the convenience sample. And so lots of people have hypothesized that by prescribing testosterone, these men are out having more sex. We controlled for that in our study. We find that that actually doesn't explain all of this. In fact, it doesn't explain any of it. It's not really statistically significant. And then also that higher serum total estradiol is decreasing the risk of HPV 16-18 infection. So that led to our second study to try to understand whether or not these sex hormones were driving histological disease. And so what we looked at was we went in and we looked at the relationship between sex hormones and the risk for histological precancers, these high-grade squamous intraepithelial lesions. And we controlled for the effect of HPV 16 and 18 and other HPVs as well in this analysis. Half of the study subjects in this particular study were recruited by my group as part of our R01 and some other work that we did with the MAX. So there were 214 HIV positive and negative men. And they were enrolled in the multi-center AIDS cohort study. Of them, they had 336 HRA visits with corresponding histology specimens. So if you get pap testing is not at all precise. And so the gold standard in this work is really to do high resolution endoscopy and be able to visualize and do targeted biopsies. In the study group that we have, where we recruited 476 men, we had 52% of the HIV infected men had high-grade disease, and 38% of the HIV negative men did as well. We repeated again, these are different specimens that are cryopreserved serum specimens. That's why not everybody in the top study comes down and is part of this, because we had to have both cryopreserved specimens that corresponded to this high risk, high resolution endoscopy examination. We repeated all of these serum studies. We looked at HPV testing as well. And to show you that we actually did the big analysis, I'm happy to share this with anyone, but I won't put you to sleep with large tables and numbers, is that what we tend to find is that when you look in histological disease, the effect of testosterone, once you control for the effect of HPV 16-18 infection, which we believe is supported by the testosterone, the effect goes away. So it in and of itself is not really contributing to the risk for histological high cell. And so the other thing that we found is that those, in fact, the risk for high-grade disease or high-grade dysplasia, these precancers, is actually twofold lower for every natural log increase in their serum estradiol. And so again, we're finding the same relationship of a protective effect of estradiol. And so we also found that those that were HPV 16-18 infected, which is good news, that it's consistent with our expectations and with the literature, that tends to increase the risk for high cell by 4.3-fold. So the take-home message from this was that the serum total estradiol is protective against histological high cell. It's a precancer. And although serum testosterone was not associated with the risk for H cell, it's really that it's operating through this HPV 16-18 infection risk. So our potential hypothesis is really that testosterone is supporting infection indirectly and driving precancers, which is informing some specific aims on the grant that I'm writing at this point related to being able to follow people before and after they go on testosterone supplementation for hypogonadism. And then the last study was to try to understand further what's going on with estradiol. So this is the last study so far in the series, and it's hot off the press. We just got the results from the histology lab in the last 10 days. And so what we did was we evaluated these associations between serum sex hormones and histological precancers, these high cells, controlling for this effect of 1618. There's 101 participants in this study, not 214, because I control the biopsy specimens for these 101 participants. And we had additional information that relates to their serological levels. And we were able to have enough tissue to be able to examine the estrogen receptor 1 alpha using immunohistochemistry. What I will tell you that went into this is that it's been debated back and forth. We did some preliminary analyses and we found that there were no progesterone receptors and no androgen receptors in tissue in the anal canal, but the estrogen receptors were present. And so we went forward with that particular assay. And so these are the findings. And so what we find is with every natural log increase in testosterone, there's not a statistically significant risk of high grade, which is consistent with the prior study. And with the total estrogen, in fact, once we've put the estrogen receptor 1 alpha into the model, it's even more protective. And we find that with every % increase in the immunofluorescence, it's really decreasing by about 4% the risk. So it's the added effect of both this regulation of the estrogen receptor. So one of the things that we're trying to understand better is how do we begin to think about estrogen receptor? So we looked in the folks that don't have high grade, and it's a small number, 58, and we see this inverse association that as the % of the immunofluorescence is going up, well, we'll reframe that. As the % of as the log of the E2 of the total estrogen is increasing, there's a diminution of their estrogen receptor in tissue. So that's informing our hypotheses as we move forward in longitudinal study proposals. So what we tend to see is that these independent effects of estrogen receptor 1 alpha, it's modestly protective with every %, but the cumulative effect appears to be important, and it seems to contribute to the protective effect of estrogen, the total estrogen in serum. And so what we think is going on is that really that serum testosterone is really increasing this risk for these oncogenic HPV infections, which are chronic and they evolve over years. It does not seem to influence directly the histological HSIL development, but it does influence the risk for these infections that lead to this precancer. And the total estradiol is really protective, showing lower risk for HPV 16-18 infections and histological HSIL. And so estrogen receptor 1A adds modestly to increase that protective effect for histological HSIL or these precancers. These are my collaborators over these 3 studies. There's been just a ton of interest and enthusiasm within my own research group. My collaborator, Ravi Jasuja at Brigham's, and Todd Brown are the 2 experts that I work with that are endocrinologists. And so and Dr. Basine has done all the lab work with Steve Whitford and the study group back there at Brigham's on all the serology. And then our funding agencies that supported all of this work have been through the National Heart, Lung, and Blood Institute, NIAID, the NCI, and we appreciate all of their support. And then I have this big sign up here because I get so nervous about doing these things, saying, be sure to thank you, meaning I wanted to start by saying thank you to everybody for inviting us to talk about this. Dr. Ahn and the research committee have been very gracious in allowing us to come and talk. I'm really excited about the people that I work with and continue this work to see if we can sort this out much better. So thank you all.
Thank you so much, Dodi.
Okay.
So Benissa, would you like to start Q&A? Benissa, you are muted.
Thank you so much, Dr. Wiley. One of our attendees asks, I may have missed it, but are these studies of MSM comprised of subjects who have more than one partner?
Most of our, and that's part of the big chart. I'm happy to send anybody that wants to read about it. We have some published articles that can tell you. This is a cohort that I was sort of born as an epidemiologist into in 1991. So I joined the multi-center AIDS cohort study as a predoctoral student and did my postdoc with them and continue to collaborate with them. So over a lifetime, these people were recruited largely in 1984, 85. And so generally speaking, partnerships have decreased over time, but this group of the original cohort, the average number of partners was very high in the first 3 years of the study. What you tend to see is that they have very high rates, and by the third year of the study, we're down to one partner per year. But the difficulty is that over time, they haven't measured how much of that is serial monogamy versus the same partner over the whole period. So the highest likelihood, we measure the 24 months prior to every event that we're looking at, because in HPV that tends to be highly relevant. It probably predicts past behavior as well. And what we tend to find is that more and more, especially, I could go on forever, but especially when you're looking at the older men, they tend to be having fewer partners at this point than they had in 1984. And when we reopened and brought in a large proportion of the cohort that is ongoing of minority men, they're not necessarily reflecting, they're definitely different birth cohorts. They have different approaches to their relationships. And so compared to men that I work with right now in both groups, the men from the original cohort were 30 years on average when they were recruited 40 years ago. So they're closer. I have some that are in their 80s, and they still have partnerships. So I would say these are sexually active men on average, and they may have many partners, they may not. So that's a long-winded way of saying yes.
Thank you, Dr. Wiley. Your next question is from Dr. Devon. She says, thanks for this interesting presentation. Do your findings have potential for new therapeutics? Or is HPV vaccine and prevention the best strategy to reduce the incidence of anal cancer?
It's definitely the best approach for producing a reduction in anal cancer moving forward. Its efficacy in people that are in my age group or in people that are in many of the age groups of people on this call that are over the age of 27 are highly debated. So while you can now get a vaccine up to 44 years of age, legally, I mean, the FDA has now made that an on-label for both males and females. The reality is that its efficacy in reducing cancer is less in the older age group after the early 20s. But, you know, I'm still a believer in vaccine, and I think it's something that's helpful, but I don't think it's going to solve this problem. And we probably have another 50 years to struggle through cervical, oropharyngeal, and anal cancers from HPV.
Thank you, Dr. Wiley. Your next question is from Dr. Lauren Clark. It may be a little early in the research trajectory to anticipate this, but let me ask anyway. In addition to HPV vaccination and condom use, do you think there are other possible preventive strategies we could imagine related to the hormonal risks you found?
Well, one of the things we're really interested in, so what I didn't say is that we've already started collaborating with my colleague, Jordan Lake, who left UCLA and went back to Texas. I keep always telling her she's still in Texas. But the reality is that she has this wonderful clinic for us to answer some of these questions. So we also work with male to female transgender women. And so there's been a hot debate in my peer group of scientists about why different people tell me that I should be looking at cis women as a comparator for these men. I don't believe that's the case. I think that what we have to look at to understand the underlying science before we start telling people what to do is to really look carefully at who the comparator is. So what we're trying to do is we're actually recruiting people. We're going to look at them longitudinally as part of the new proposal we're submitting to use a trans female population, because they have voluntarily gone in for hormonal therapies that reduce their testosterone and increase their estradiol. So what you might see is you might see a wholly protective effect, which I don't expect to see. Their estrogen levels rise from about 3 picograms per mil to maybe 300 picograms per mil. But what you might see is a U-shaped curve. And there's a lot of phenomena biologically that have these U-shaped curve, where in fact there may be a sweet spot where a low level is protective, but on both sides where it's either really, really low or really, really high, you end up getting a disease state. So I think we have to stay tuned. But I think Lauren and Lauren is my partner on a study with Optum, and also some work we're going to do moving forward on HPV vaccine, is that I actually think this has promise for informing testosterone management in hypogonadal men. Because, you know, one of the study sponsors here in town was telling me, the study coordinator was telling me that men were skipping into the office so excited to get lots and lots of testosterone because it relieves all of these symptoms of hypergonadism. And so fatigue as well as libido and so forth and so on. But we've learned the hard way through women and menopausal treatment, postmenopausal treatment with estrogens, that, you know, managing that is a much finer craft. And I think that's going to be the long-term lesson, is to try to inform people about the risks and how you begin to manage that. So it may be that they need to have more screening. It may be that they have fewer partnerships, but most of these infections are long-term. They've been long-standing. Okay.
Thank you so much, Doctor.
Yep, thank you. I hope I didn't put you to sleep too fast. And thank you, Batson.
Dottie, it's amazing. I have actually one question.
Sure.
Is there any evidence that testosterone is directly acting to increase the HPV infection or replication?
Well, when we control for, that's been part of the hot discussion. The first time I presented these data at an international meeting, the people that hopped up from their seats and ran to the microphone just happened to all be men. And they kept saying to me, no, you're just not controlling for their hypersexuality associated with testosterone. And I said, but here it is. And I brought up the chart and I showed them all the estimates and how we controlled for this. The number of sex partners doesn't explain it. It may be operating on the actual virus or the microenvironment for the virus. Remember, this virus actually has many different ways in which it influences the risk for carcinogenesis. So I think that there's probably a biological reason why testosterone is influencing these 16-18 infections. Because we see that 16, for example, shuts down some of the innate immune responses. We know that it tends to turn on cell proliferation. There's all sorts of effects in the virus or in the cell that are being caused by this actual virus itself.
I see.
Yeah.
It'd be more simple maybe to set up an in vitro cell culture system.
I'll call you tomorrow.
Okay.
Okay.
That'll be a successful collaboration.
Thank you. Thanks for your time.
Thank you. Thank you, Dottie. So let's move on to our last speaker. I'd like to introduce Dr. Wei-Ti Chen. She is an associate professor in our school. She's going to present her research, which is Project Burmese, what we learn on the current situation in Myanmar. So please welcome Dr. Chen.
Thank you. Can everybody hear me? Hi, my name is Wei Ti Chen. I have the honor to receive the CTSI School of Nursing Intramural Fund back in 2019. That is how I started setting up the projects that this is a global projects that doing HIV related projects. As a researcher in HIV care, that I'm always interested about how people are taking care of their HIV disease and how did they learn and live with the disease every day, like living, and especially in Myanmar, which is a country that recently has been opened up after 2015. Aung San Suu Kyi become the controller in the background. It becomes one of the democracy country in Burma, and so we have the chance to get into this the countries and then to start learning about how they live with HIV and what helped them to decrease the stigma and how do they live with the stigma in HIV related.
So last night I had to have a talk with your dad because.
Okay, so you might have some question about why we call the countries Burma or Myanmar. It's quite interesting. Myanmar is a population of 50 to 60 million. It is located somewhere in Southeast Asia, East Asia, and Southeast Asia converge, which is bordering with China, India, Thailand, Bangladesh. It used to be one of the countries that we call it a land of gods, and back in about 100 years ago when British colony. During that time, that 1/3 of the rice were produced in Myanmar, and then it goes out of country exported. And so at that time, Myanmar is one of the wealthy country in Southeast Asia. Is much better than Thailand. But because of the military ruling, and then over the past 2 centuries, that has been political unstable, and after the colonization, the British left the country, and independent within 2 years, the military rules, and recently it might goes into civil war, and so the country is getting become one of the poorest country in Southeast Asia. So talk about why we call it Myanmar or Burma. In fact, that in back to 1989, the military rules decided to change the name to Myanmar instead of Burma. Burma is one of the ethnicity in country called Burmese, and then at that time that they used the country name as a Burma. And people inside, they feel that we should not using one ethnicity to representing all the countries. So that is why at that time the military ruling changed the name back in 1989 from Burma to Myanmar. At the same time, because many international countries are not recognizing the military ruling, so they still using the Burma instead of Myanmar. So it's quite interesting that not just only the flag has been changed from this old flag and to the to this currently the 3-color yellow, green, and red color up-to-date country flags from 89. So currently in that internationally, you can see Burma or Myanmar at the same time they calling this country. Okay, so when we start thinking about the projects, that we know that Buddhism is one of the heavy influencing religions in country. About 90% of the countries people are believing Buddhism, and it's really helping that people shape their daily lives and their values, and it's quite understand how they helping them to understand how the illness process in their everyday living and practice. Especially we want to know about how the religions and impact on their HIV care, especially. However, that really limited information about on HIV care inside the country and how the stigma has been impacted. So we came up with this project, and hopefully we can interview that HIV positive individual to know a little bit more. So some current facts of Burma is one of the poorest country in Asia. It's about 1/3 of the population lives in poverty, and now the percentages might be going up as the COVID impact and the coup have been impacting the whole population. Because of poor infrastructure and very, very heavy corruptions with the military government, and ill treatments for those ethnicity minority that you have been heard of, for example, like a Korean minorities or Rohingyas. However, those people are really mostly located in rural places, and many of them are stateless person because the government doesn't recognize them that as a part of the citizen inside Burma or Myanmar. So that means that those people don't have the citizenship to travel anywhere. Also, they have remained border disputes in the country within Thailand and within India, and especially with China. And human trafficking is one of the issues, and then drug trafficking has been, Myanmar has been one of the countries that producing opioids to export it to overseas. So that is also one of the issues inside the country. So talk about Myanmar HIV's current situation. The closest stats came from 2019 from UNAIDS. So about 240,000 people living in HIV currently. About 0.7% are in adult population. New HIV infections is about 10,000 per year. 7,000 HIV-related death per year, and 77% of adults are ART, and 73% of children are currently on ART. So it's published from the Myanmar government that currently people living with HIV are diagnosed among substance users, sex workers, and MSM. I'm personally very surprised that the government will use a sex worker terminology in their governmental documents, because currently internationally we rarely using sex worker instead of the sexually transmitted individuals, because we're really hard to define what are the sex worker, because people who have using sex to exchange not just only money but also other substances too. So we don't usually call them as sex workers, but more like how they infected the transmission routes instead of the occupation. The mortality rate among people living with HIV in Myanmar is about 6 times higher than the US people living with HIV. Especially is very, very high attrition rates in the HIV care continuing, which means that when they are diagnosed with HIV, they might not even come back for picking up the medicine. Even though they pick up the medicine, they might not continue picking up the medicine. So the continuance are disrupted in several stages during the HIV course. And so far for the 90-90-90 that UNAIDS setting the goal, WHO is setting the goal that only 77% of the HIV positive individuals or in Myanmar are on medication. So it's still in top 10 causes of the causes in Myanmar, and HIV is one of them. So this is what was the photos that I took back in last trips that we were in Myanmar, that we're working with MPG. That means that Myanmar positive groups, that they have the wide extended networks that working with all the HIV positive individuals in Myanmar. So the study purpose is that we want to know about like how the Buddhist concepts of conceptualization of the HIV stigma in Myanmar and culturally adapted the testing and feasibilities of an intervention later on for those people who are living in with HIV in Myanmar. So talk about HIV-related stigma. Stigma is one of the major risk of the factors that well-being and survival of people living with HIV. So talk about stigma, usually they have internal stigma or external stigma. For example, people feel that they are stigmatized is more like we define as a self-stigma. But people thinking that outsider will stigmatize them is more like external stigma. So for example, in COVID pandemics, people who have COVID, we might be afraid a bit that people who might have COVID walking on the streets. So that is kind of like external stigma. But internal stigma is more like, I have the disease, I feel that I will be stigmatized. So that will be different kind of concepts, especially talk about stigma. So this photo was took in CNN report back in 2013. So HIV positive individual in Myanmar has been long isolated that has been reported widely. So the study aimed that we want to conduct in 30 HIV positive individuals is in Myanmar, and to talk about their experiences with HIV and talk about how the religions or Buddhism conceptualization has been shaping their value and HIV care. So after the first stage of the study, then we will adapt the intervention to fit into culturally tailored into this population. So what we have been completed. So the IRB has been proved back in 2019. So we started the in-depth interview with 30 HIV, in-depth interview with 30 Myanmar people living with HIV in Yangon. And those people working with closely with MPG. And this photo was taken back in 2019 that I gave a talk to University of Nursing that the women sit right next to me is the rector of the university. So we are lucky that we train our collaborator at that time. This is one of the in-depth interviewer that helped us to conduct the in-depth interview. So we completed and before this the in-depth interview. So before the summer of 2020 that pandemic hits and the country has been locked down during last year's around summertime, late summer. So this is the photos that the MPG, the yellow dots means that they do have a 500 HIV positive individuals under their MPG care. So they do have a peer support groups on site. And the orange dots means that the sites might be a little smaller, might be 250 HIV positive individuals that. So there are about 80 dots in this maps that they have 80 different sites that and here's are the Yangon that sites that they have the biggest central offices located right here. So after the COVID pandemic hits that we started interview. We finished the in-depth interview and then started transcription, and we asked them to do the transcription and translation back home. So currently we do have the raw data come back to us, and then we are trying to do the data analysis using Atlas DI. So while we are doing the coding, at the same time, we are trying to adapt one of the interventions from Laura Bogard from Orient, and then to translate it and then adapt it to Burmese version. However, I'm still really doubted that whether we can still adapt it and test it in country as the military coup starts. So this is one of the photos that back in March over 2021 that they are starting the pandemic care, and then those people volunteers who are working inside the pagoda to clean and sanitize that the pagoda. But however, you can also see that not everybody wear a mask. So to share some of the information, what are the stigmas that they have experienced from the study participants? One participant who work as a blood drawer phlebotomist. Oh, okay, I cannot even say that out right. Anyway, so she works in this facility that drawing a lot of blood with HIV positive individuals is on site. However, when she diagnosed with HIV, she is so afraid that her colleagues will know about her zero status, and then she even think about she need to resign from the work, and then and she doesn't even want to go to work. But at the same time that privacy is one of the issues that almost everybody will know that the status because of the care system inside the infrastructure. Okay, so also in other people shares that in the same community that people know that he has HIV, then those people will come to him, but not talking to him, but say talk about HIV in front of him, making him very, very embarrassed, especially when they are going or doing the meditation in pagoda. And other people, HIV confirmed healthcare providers described that none of his coworkers were willing to take the same elevator with him, especially when people saw him coming to the office, they just going out the office right away. So those kind of like subtle or micro aggressions that will make those people very, very upset. And talk about the religions that one participant talk about that because I'm still breathing because I'm a Buddhist and I read the Buddhist scripture every day. By reading it several times a day, I can regain the energy to live. So meditation is one of the very widely practiced behavior. And other people talk about I'm Buddhist, so I know this disease because I got my sin from the previous life. I'm praying every day to hope the medication is working and make me healthier. So I should not let other people get HIV because of me. Otherwise, that the sin will pass down to my next life. So incarceration is one of the very important my set is in most of the participants in our in-depth interview. So for people who with Islamic backgrounds that will share that people with Islamic backgrounds that believe people got HIV are people with sin. In fact, that many HIV positive individual are contact from their spouses. So that is why I don't dare to explain anything to my people. That will also make the whole disease disclosure harder. That means that not just only talking about the disease to her family member, but at the same time, including her support system. Others discuss that Buddha would not discriminate them. Then the Buddhism teaching states that everyone is equal. That means that people living with HIV should be the same as people without HIV in the Buddha teaching. So in Buddhism, that everybody should be equal. Then you should make yourself better, and then while you are taking care of the rest of the population. But in fact, that how many people really can remind them under this kind of religion's heavy influences are hard to say. So talk about 2021 military coups that you saw on the news is that the situation is getting worse and worse with the CDM that called that civil disobedience movement. That means that almost all the governmental workers are not going to work as not supporting as showing not to supporting the military government. So people are on the streets and then doing the military coups, and this you can see this is the one of the this is the military who recently have operated coups, and that is a lot of like seems that you can see on the street that and also the younger generations are on the parades almost every day is on the street that you can see on the news, and the military is also open fire on the streets. So this that widely spread that nurses and doctors and monks are all against the new military regime, that they want to go back to the democracy. So this is recently took photos that that younger generations are not really going back to school, not to go to work, and then really the society is on hold at this current time. So so as a researcher in countries, so my teams and I are thinking about how should we really not to get involved, but let the whole international researcher to know that chronic disease, patients with chronic disease having issues to go out to seek health care, especially in this kind of situation. Not just only healthcare provider, they are not there to go out of the house to work, but at the same time they cannot take care of the people with wounded on street and also inside the hospital, because when the military know that those healthcare providers are taking care of the gunshot wounds, the hospital will be targeted. And at the same time, those people who are working on the street to go to the hospital, pick up their medicine, also have risk to be shot at. So the whole situation is getting worse. And so they will come to my end of my presentation. But just to share a couple more photos with you, that was the photos the first time that we went to the capital city to meet with those governmental officials. And this is one of the pagoda, which is really bright and peaceful. And this is the front door, and then inside that you can see the men who are doing the worships, and then pulling water on the Buddha. And this will be the last photo of my share, that people there in Myanmar really believe that every tree and every object do have a Buddha inside, that is how they worship the big trees, and then they just give them some clean water to worship. So any questions?
Thank you so much, Dr. Chen, for that fascinating presentation. Your first question is from Dr. Devon. Based on your data, it seems several of your participants believe that they got HIV because of their quote unquote sin. Is this stigma more prevalent than the stigma of the disease? Second, what types of interventions might be appropriate under these circumstances?
Okay, so yes, the stigma is prevalent, but in fact that people are not openly talk about HIV, at least from our experience, but it's more like a secretly gossiping that people, especially Myanmar, is a collective society that you can feel something is not right, but you still need to living in the same environment with those people. That really feel them as a little bit depressed. But at the same time, because of the doctrine and the theme, feeling that they got the diseases because of the previous life are suffering, so make this life is more suffering, so that will make them to push them a little bit closer to the religions, that to gain some inner peace from the religious practice. At the same time, that after they think that they treat themselves good, so the same won't pass down to next life. So the intervention that we are hoping to adapt is how to help them to more positively thinking. That, for example, that we are thinking to encourage them that if you can take care of yourself currently in this life, then if you have a stronger body and then stronger mind, then the theme might not pass down, which means that we are hoping that we can involve with those religious leaders to help us to deliver those positive thinking and make it more self-management is better. And that is the thing is that we are trying to adapt it from Laura Bogart, that she does have a one intervention that she delivered into the racial discriminations in HIV positive in individual in Hispanic population in the States. However, because the populations are different, the religions are different, so we are trying to make sure that the intervention can be adapted and then can be useful in our population back in Myanmar.
Thank you very much, Dr. Chen. I have a question. Have you considered measuring internalized stigma, and what kind of interventions do you think also can address internalized stigma?
Yeah, well, yeah, that is quite interesting question. In fact, that currently all the interventions are really more geared toward the internalized internal stigma instead of external, because external stigma really need to be intervened from the governmental or societal perspective. But internal stigma is really more how to encourage them to have a better self-management, that when they are taking care of themselves much better. For example, they need to know how to disclose their disease and then getting the support and resources from outside. And whether that outside is from their family member or healthcare provider or the outside resources is one thing, will be the key to help them to decrease the stigma. That is quite important. But before we can get into that stage, disclosure is the key. How to prepare them to talk about their disease is one thing. From my previous study back in Taiwan and in China, and even in Thailand, that those people are really things that you will need to openly seeking resources to help you. So your person self-stigma can decrease. So stigma are highly associated with stress and social support. So that means that people with higher social support, the self-stigma will decrease. So the mediations will be important. And at the same time, mindfulness and religions are also playing in the key. So decreasing stigma, there are so many factors we also need to consider at the same time.
Very interesting. Your next question is from Dr. Lauren Clark. Do you see Myanmar moving toward a more secular or more fundamentalist religious experience? And how might HIV stigma change as religious fundamentalism changes over time?
It's quite interesting question that because we don't want to get into two bindings on the religion, because as we talk about that 90% of the population join Buddhism, but not everybody join Buddhism, because in 100 there are more than 135 ethnicity inside the countries. There are also Muslims, and at the same time with Catholic and Christians inside. So we don't want to stress too much about that Buddhism is the only thing that inside the country. But at the same time, because people living inside the countries or grew up with some kind of influences of the karma or the Buddhism concept, even though they are not going to the pagoda, but they understand about what that means. For example, people not in Buddhism, but also will tell you that today I have a bad karma. Karma concept is really come from the Buddhism, but at the same time, they will feel that that is because I have a bad luck. That might not really be 100% really related to Buddhism, but it's more like from their cultural values. So we are not want to get into too detail about the religions that because the intervention really want to know about how to help them for self-management, but instead of the change their religious behavior or getting more detail about their religions. Hopefully that I can answer your question about this. That is my ideas of the how to adapt that intervention, but not changing their details of their fundamental religious belief.
And I have one last question. And how do you define the Buddhist conceptualization that was in one of your aims?
Yeah, so Buddhism is that just mentions that Buddhism conceptualization. We just want to ask about. We did ask about the questions about. Tell me about your religious practice. So how often do you think that? How does the religions that help you to shape your everyday life, and how does that importance to you? So we didn't give them the religions that we want to. We didn't give them the answer that we wanted them to go into Buddhism. But for example, many of them who are not Buddhism will also talk about their Muslim backgrounds, and how did they practice the Muslim practice, and then what are the practice they are doing, like almost impacting their lives. But however, that we also ask them in more detail. So you grew up in the country, so people are doing this kind of practice, especially in the Buddhist New Year. Does that impact you, or what did you see about this kind of situation? So they will also share that yes, they grew up with their friends or close friends or all in different religions. How did they see them, and whether those internal or external conflicts will make them see themselves differently. That is become one of the interesting themes that we have been seeing, that because of the current military ruling, we're trying to play the role as a Buddhism against to the rest of the religions will make dividing the whole country in different pieces, that we also have some kind of sense before the ruling, the military ruling. So we are kind of like trying to digest what does that impact on everyday lives for those HIV positive individuals.
Thank you, Dr. Chen. And I will turn it over to Dr. On.
Thank you, Benissa. Thank you, Waity. It is very incredible work. I know that Myanmar, there are so many difficulties. People are suffering. Your research is very important. Thank you so much. This is going to end our oral presentation session. Thank you for our faculty, presenters, and questions and audiences. Thank you so much for this very important our research presentation, annual research day for UCLA School of Nursing. Thank you so much. I like to especially thanks to our team for developing this incredible event. And Holly Devon, she is also contributing significantly for our school promoting research. Thank you for Gamma Tau at large chapter of Sigma for funding to support poster award for the top 5 posters. We are currently selecting, reviewing top posters. So we have more than 60 posters, which is amazing, showcasing our research activities from students and faculty. I am very happy and very excited that we have such an excellent, successful research day event in our school. And I finally like to highlight Benissa Seram. She has done so many work on incredible talent for converting the School of Nursing Research Day into virtual research day for last 2 years. Thank you so much, everyone. I hope you are safe. And thank you for Dean Sarna for the introduction and leading our school. I've been having incredible time in the School of Nursing. Hope that we can continue to grow our research in our school and promote our research and educating our incredible students. Thank you so much, everybody. Have a nice day, rest of the day, and then please stop by, poster session, leave your questions, and we will hope that we enjoy our research day, and maybe we can come up with nice collaborations. Thank you so much, everybody. Bye-bye.